This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week I'm coming to you from a secret bunker deep beneath the Hualapai Mountain campus. Actually, we've displaced Dr. John Ashurst. We are talking with some of the residents involved in the KRMC Emergency Department Residency Program. I've got two young docs here with me, Dr. Max Doherty and Dr. Mitch Loehmann. Guys, welcome to the program.
Thank you. Appreciate it.
Thanks for having us.
Yeah, I'm excited to talk about residency and learn a bit about your experience here. First, I should ask where you come from, what universities you went to or are still involved with, and how that works.
So I'll go first.
Yeah.
I graduated from medical school at St. George's University. That is out of Grenada in the Caribbean. You do the last 2 years in the United States, which I did in Chicago. So I was there 2021, 2022, and then 2023, matched down here, moved down to Kingman, Arizona.
I did my medical school actually with Midwestern down in Phoenix, Arizona. Spent the whole time there, most of my rotations, both on the east and west side of Phoenix.
And the residency program itself is 3 years, right?
Correct.
That's correct.
How often are you guys working? What is a regular schedule for you?
Very busy.
Yeah.
Yeah. So it kind of changes year by year. Usually your first year, you're working a lot more hours, more on, off-service rotations, we call them, things like doing the OB-GYN rotations. You also do like pediatric emergency department up in Las Vegas, and a lot of other off-service rotations. A bulk of it is in the emergency department where we specialize. In first year, we're doing roughly 19 shifts every 4 weeks. And then you kind of drop down a shift to 18 shifts by your second year and down to 17 shifts by your third year.
Okay.
And the shifts are 10 hours long. So most of the time it's 4 or 5 days a week. So pretty busy.
That's pretty busy.
Yeah.
Yeah. And that could be, are they fixed hours for you, or is it now your days, now your nights?
They're all over the place.
Yeah.
Yeah. You're kind of constantly flipping from doing a 6 a.m. shift, doing an 8 p.m. shift, going back the next day, doing a 10 a.m. shift.
Yeah.
Yeah. So it's a pretty rough sleep schedule at times.
How do you manage that?
Blackout shades.
Yeah.
That's pretty much
Right.
blackout shades and melatonin. That's about it.
Is it really? Yeah, you have to, in order to function, right, you have to find a way to get your rest.
You got to be able to flip-flop back and forth. And some people definitely have a problem with that. I know some of the attendings will come in and you'll see them for like administrative meetings in the morning, and then they show up for their night shift. And as they're signing out, they'll be like, how much sleep did you get? And like 45 minutes.
Yeah.
And so sometimes you can't. If you got kids running around the house and it's Arizona, there's a lot of sunlight creeping through every crack, so it can be hard to get some sleep.
But sustaining yourself and making good medical decisions on 45 minutes of sleep, that's a limited time offer, right?
Yeah.
You got to find a way.
You can get through one shift
Right.
On that, no problem. And then by the time you're done with that shift, you can't stay awake anymore. So then you get a good amount of sleep the next day.
Kind of catch up.
And it just it ends up working like that. But I think a lot of us have bought stock in Celsius energy drinks too.
Yeah,
So.
steady trickle of caffeine.
Well, so your faculty, they're preparing you for all the medical and clinical stuff you have to deal with as ER docs. Do you talk about that kind of the real life stuff about like, how do I get enough sleep? How do I function? Do they talk to you about that stuff?
Yeah.
Dr. Loehmann is actually our wellness champion.
Yeah.
There's been a big push on wellness, not just in like emergency medicine residencies, but in all specialties,
medicine, right?
And like across medicine in general. They're trying to move away from the days where it was 100-hour weeks and no sleep and you're on call for 48 hours straight, which that's never really been an emergency medicine issue. Emergency medicine is very much shift work. You go home most of the time on time because somebody else is showing up to take over for you. And you don't have to be finished with a patient. They'll just pick up where you leave off.
Yeah.
So that was one of the draws
it's
to
helpful,
me
right? Yeah.
for emergency medicine, as opposed to, ICU docs that will be on call for a week straight, or surgeons that do that, hospitalists, that kind of stuff. So.
What's the process of matching with KRMC? How do you get assigned here?
Ooh, the process of match has always been a mystery to me. I don't know if Max has a better answer for it. Yeah, to this day, I'm not really entirely sure how it works. You go through the process of med school, deciding what specialty you want to go to. And then kind of your fourth year, you do auditions where places you plan on possibly, doing your residency at. And then there's a whole process of doing interviews with these places. And then the residency program itself has a process where they rank people that rotated there, people that interviewed there, depending on who they want to come to their program. And then the medical students themselves do the same thing. They rank which programs are the highest down to the lowest, where they prefer to go. And then through some magic algorithm that none of us understand, you get matched into a residency.
A spin of the big wheel, perhaps.
Yeah.
Put all those numbers into a supercomputer, and then it spits out lists of where everybody's going. So it is very much an algorithm, and it's kind of a terrifying process because it's not like you're applying for a job and getting hired there.
Right.
You are at the whim of this algorithm because, you can make your rank list what you want, and the programs that like you can rank you how they want, and you may end up somewhere completely different. If you both put each other as number one, you're probably ending up there. But otherwise, that those large numbers can cause some pretty big swings.
Yeah.
So every med student goes through that to match into anything, but it's honestly, it's terrifying.
Yeah.
It's a lot of
big day.
A lot of stress.
Pack your bags.
Yeah.
Right. Mm-hmm. Once you get that notification, how far away? So it's March, and then is the incoming group, is that July? Yeah.
July 1st is when most programs start.
There's a little bit of time to get ready.
Yeah. And usually it's
better than graduation from med school. It's like as soon as you match, it's a huge relief.
Yeah. I'd like to talk with you guys a little bit about why you chose emergency medicine. Dr. Doherty, you mentioned part of it was kind of the way work is structured, but I'm sure there are other factors that attracted you. Why emergency medicine?
Yeah, so shift work for sure. Every job I'd had up to this point was shift work, so it's just kind of my preferred way to work. I don't need the 9 to 5 necessarily. But also I went with emergency medicine because when you start to go into some of these specialties, you end up losing big chunks of the types of illnesses that you're seeing. For example, if you want to go even if you want to just be a hospitalist, which is still very, very broad, or like family medicine, you can start to miss seeing like some of the psych stuff or some obstetrics, gynecology. You can get into a point where you're not seeing pediatrics anymore. In emergency medicine, you don't really get to pick. You have to see everything.
Whatever shows up through the door, right?
It's kind of that, jack of all trades, master of none. You have a very surface level understanding of pretty much everything, which not every other doctor can say. The more you specialize, you tend to get really good at that one thing, which is absolutely needed and necessary. Yeah. And then you don't, you never think or read about any of the other stuff anymore, and you kind of lose it.
Yeah.
Which there's stuff that we don't deal with that I've lost. Some of the really like chronic diseases that you aren't necessarily right now emergencies, or really, really specialized stuff like autoimmune disorders and things like that, that we don't really get to see. But
the breadth of the medicine is what attracted you.
Yeah.
And Dr. Loehmann, how about you?
So I definitely agree with the breadth of medicine you know. That was a big appealing factor for me. I also before medical school, I did medical scribing, and I worked in an emergency department. And it was when I worked there that I kind of realized that this environment suited my brain very well. I don't want to say like ADD type people because I don't want to speak for everyone in the specialty, but to me it's that kind of sense. It's like this organized chaos where you have 12 different patients with 12 different things going on, and everything's happening all at once, and being able to organize that in your brain, it's a very satisfying feeling to me. And then there was actually a point in medical school where I thought I was going to go into surgery because I really like the procedural aspect of medicine. And then I realized that 5-year residency for general surgery and the call shifts and the hours, I don't know if I would have made it through that. So emergency medicine is kind of that happy medium of getting the medical aspect and the surgical aspect of both sides.
I spoke with one of your faculty members, that's Dr. Clark Snodgrass.
Yeah.
I was asking him, is there a certain type of person attracted to emergency medicine? And he said, well, oftentimes they're adrenaline junkies. Can you guys corroborate that?
Yes,
Oh,
they
yeah,
are
very
definitely adrenaline junkies.
Are you guys prone to jumping out of planes or anything like that?
Yeah, I mean, I've done bungee jumping.
Yeah.
I haven't done any skydiving yet, but I
will?
definitely
Come
want to. I want to. I haven't had the opportunity to yet.
Okay, all right.
There's definitely the stereotype of the emergency medicine doctor being like a mountain biker, free climber, parachute.
And
We'll say skydiver, not parachute person.
it's what's the confluence of interest? Is it or what is it? I don't want to put words in your mouth.
Sure. It's you enjoy the rush of things are bad right now.
Yeah.
Because usually the sickest you're going to see somebody is when they come into the emergency department, and at that point in time, you have no information. When they're getting up to the ICU, well, they've got all these labs and all this imaging done, and we have a story to tell them. But when they're first walking in through the door, sometimes just like they get out of their car, walk into the lobby, and then you just see that they're super, super sick, and you have no idea what's going on. And you kind of have to figure that out, sometimes really fast, if you don't want things to go sideways.
Yeah. Do you have cases where you have because usually somebody will have transported or something, right? Do you have the case where somebody comes in on his or her own, keels over, and you have no information whatsoever?
All the time.
Yeah, many times.
It happens often.
Many times.
People will drive their family members in, and so they'll pull up in front of the emergency room lobby
Good
and
luck.
say like, hey, this is
It's amazing.
they're not feeling so good, and you get out there and they're either altered, or we've had people that we pulled out of vans that are pulseless, and we have to start CPR on the sidewalk right there outside. So that kind of thing happens not infrequently.
When you say altered, is that like in some kind of intoxicant?
Oh yeah, like their mental status is not right. They don't know who they are. They don't know their name, where they're at. That kind of stuff.
And you don't know either. So now you need to start figuring things out.
Yep.
And fast.
Yep. And there's a lot of things that can cause it.
How stressful is that?
Yeah, it's very stressful. Yeah.
It's a lot more stressful at first.
Yeah.
When you are like brand new intern running through it, it can get a little overwhelming, but eventually you see so much of it that you get kind of this.
You have a process.
Yeah. You go into an algorithm.
Okay.
It's like, okay, well, what's wrong with them? They don't have a pulse, or here's the 10 things that I can do something about.
Mm-hmm.
Let's see what we can figure out based on those 10 things. And
what do I need to address first? What's second? What's third? And then kind of work from there.
You said it can be overwhelming when you're first starting and it's fast and it's chaotic. Do you remember a moment where later on in your progression where you were like, oh, I can do this? Do you remember that feeling?
I don't know if there was ever like a specific period. It's kind of been like picking up like gradual process over time.
Yeah.
I don't know. I guess, just kind of reflecting on the experiences I had intern year versus the experiences that I had now. I can definitely see the growth, but I don't know if there was a specific period in time where I was like feeling that way.
it is very incremental. Yeah. I do have one, like a story where it was like,
Oh, please. We love stories.
I hit right here. I was an intern, and we were maybe like halfway through intern year, and there was this very, very sick kid that another resident and the attending were on. So they were in that room forever. She was, things were not going well, and she was going to need to be transferred out to Phoenix Children's. And while all this was happening, we're all kind of in that room, and one of the nurses just grabbed me because everybody else was packed like 4 bodies deep into this room, and came out, and she handed me an EKG, and this guy, different guy, is having a major heart attack. And at this point in time, you're pretty much running everything you do past the attending because they have all the experience and you have none. But he was very busy with this crashing kid. So I ordered the labs and I called the cardiologist, and we got them over to the cath lab before I even got to talk to the attending about it. So just got them out of the emergency room where they needed to go. And looking back on it, it's not a huge thing now. Like, that's not something that I would be like, it's not going to amp me up or like make my day if I do that. It's a good feeling. But in that moment, it was like, I just did that like wall to wall without even talking to anybody about it. And it was like 6 months ago, I would have been crying in a corner. Not have gone this well. So the first 6 months are like the exponential growth curve is huge.
Do you have shifts where you're like, early on, where you're like, I can't do this? What was I thinking? Or would you prefer not to answer that?
I don't think I had one where I regretted emergency medicine. I definitely had some shifts where I went home and just like laid face down in bed for 12 hours, but nothing that I think I knew that this is what I wanted to do. And I don't think that I've never had a regret based on that.
Yeah, no, I don't think I've ever questioned emergency medicine. And I think we actually had really good, it's like senior residents when we were interns.
Yeah.
That it was never like I was put in these situations where it was something I couldn't handle. I always had that backup to like ask me, I had this patient came in and they were super sick, and it's like, okay, well, what are you worried about first? Like they prompt you for these things to help you like grow and get better at these things. So it was never, doubting or questioning, but it was definitely, moments of feeling like inadequate that caused some self-reflection. But
I've heard plenty of stories about the senior residents kind of hazing the new guys, and they start to think of themselves as gatekeepers. But I'm also kind of wondering if that's old medicine. Do you have any comments on any of that?
I can't speak for other residency programs. I feel like it's probably more of like a thing of the past. And I know our program, at least as far as we've been here, has never really been that sort of situation. We've always, tried to help and grow the younger residents. But yeah, I can definitely see that, the hazing aspect of it was probably more of a thing of the past.
Yeah. Yeah.
Emergency medicine also tends to attract more relaxed people. You get the adrenaline and all of the stress out, in other places. And then in normal situations, you're just like, okay, this is like not a big deal. So between attendings and other residents, there is not a lot of, at least here specifically, there's nobody that ever did anything like that to me. There's nobody that works here now that I ever like dread having a shift with, like not a single one of the faculty members. I love every single one of them and am friends with a lot of them outside of like just the program itself. So it's been a very nice program for that reason. I think there is still some of that stuff in maybe not emergency medicine specifically, but in some other specialties. I think some gen surge
I was going to say, looking at you,
like
surgery.
That springs to mind a lot. And again, it's also dependent on the hospital and,
the
leadership.
culture there, right?
Yeah, absolutely.
The nature of emergency medicine, it seems like you guys understand. You got to be a team. You got to work together.
Oh, yeah. Mm-hmm. Yeah, very much so.
If you're just joining us, this is Focus on Your Health. I'm T.G. Lafredo, and this week on the program, I'm speaking with a couple of the docs with KRMC's Emergency Residency Program. That's Dr. Max Doherty and Dr. Mitch Loehmann. Dr. Loehmann, what happens on a good shift around here?
Oh, every shift is so different. It's hard to like specify good versus bad. I think the good shifts are, when things are flowing well. We have a pretty big emergency department, so when things are like evenly spread across providers, and you have nurses that are keeping the flow going well, and you have hospital providers that are admitting patients and getting patients off of our unit in an appropriate manner. Mm-hmm. So just when everything's flowing nicely is what seems like the best shift to me.
Yeah. Dr. Doherty?
I like when people are sick.
Yeah.
I like when...
Not for them.
Yeah, it is a better shift for me when you're actually dealing with emergencies, because in the emergency room, that's not always the case. Anybody can walk in and, we take care of people. Earlier, this may have been before we got on mic, but earlier we were talking about the family medicine. The lack of family medicine doctors in this area kind of leads to the emergency room here, specifically in Kingman being of us practicing a lot of...
a sort of de facto general practice.
Yeah, which, not that there's anything wrong with that, and that doesn't... there are some emergency room doctors that can get upset about that.
It complicates things, right?
Yeah, it doesn't necessarily bother me. I have no problem, being their primary care visit for 6 months, because it's going to be 6 months before they can get an appointment. So I don't have a problem with it, but my best shifts are when people are actually sick and need the close attention and some of the crazy procedures or the figuring out medical mysteries.
Yeah.
I think some of my best shifts have been the ones where the entire 10-hour shift I am running around like my hair is on fire and trying to figure out what to do with people. And I feel like I'm stretched in every direction. But then that 10-hour shift feels like it was only 3 hours. And you actually get to go home feeling like you did a lot of good.
That crazy pace is what speaks to your sense of purpose.
Yeah.
So I have a couple of kind of personal questions. I think I have your blessing, both of you guys, but
Absolutely.
We just talked about what makes for a good shift. And I'm curious about a difficult shift. And I'm curious, I guess first I want to say, like, running around for 10 hours, okay, you did a lot of good. That's a good feeling, right? How do you slow that down when you go home?
It slows down. Generally, there's a period of time where the next person comes on and you kind of hand off everything that's not tied up.
Okay.
And then you get like some time to finish notes and maybe put in a couple orders, discharge some of the not so sick people, get to all that stuff that was maybe getting backed up by the super sick people. And that slows things down. A lot of the time, you walk out the doors to the emergency room and it's like you just walk and you hit a wall. And so you're running, the adrenaline keeps you going. And then as soon as you step out into the parking lot, you're like, oh, I'm done. It's bedtime.
Yeah.
Yeah. And I don't know if that's something that you just like kind of grow accustomed to over the 3 years, is like being able to like suddenly have an off switch when you leave.
Really?
I don't know if most people could do it. I don't know if it's just the way my brain works, but I get home and I'm like, okay, things are calm.
Yeah.
Ready for bed.
What is a bad night at work?
I think speaking to the emergency department is so dynamic and ever changing. There's a lot of different factors into what makes a bad shift. I think that same thing that makes a good shift with having these critical cases and running around with your hair on fire the whole time can also make for a bad shift sometimes. Like if you have a patient that comes in cardiac arrest and it's a prolonged arrest where you're doing multiple procedures and you're in there for 45 minutes, an hour, hour and a half, and then there's 12 other people in the department. Some of them may also be sick, and taking care of that one patient also puts the other, patients behind, and then the waiting room builds up, and so these things that make for a good shift can also, quickly get out of hand. That's for sure one aspect of it. I don't know if I have a great, definitive idea of what makes a bad shift.
But you know it when it comes up.
I know it when it comes up. Yeah,
That flow question.
Yeah.
Yeah, that you were talking about,
Yeah,
the flow
flow
question.
too.
If people aren't moving,
Yeah.
whether the hospital's full, the ICU's full, so we're holding them in beds downstairs, and we've done up to our part, like we'll still, manage them medically because they're sitting right in front of us, but now they're technically the ICU doctor's patient. They're just waiting for a bed up there. But now they're stabilized and they're essentially a hospital patient at this point, but they're still holding physical space in the emergency room that somebody else could be going into. And then, I think the waiting room is a good indicator of how bad a shift is going, because as the waiting room fills up, you're either not moving people or you're having issues with, figuring out where people need to go. That can always be a problem. Different upstairs doctors have different ideas about where patients should go. So sometimes there's we'll say long conversations about which floor this patient should be going to.
Right.
And that can gum things up a little bit too. We are kind of acting as the middleman a lot of the time. When we see somebody, we figure out what's going on. We have to figure out where they're going, whether that's the regular hospital floor, the ICU here in Kingman, if they need to be transferred out to Vegas or Phoenix.
Which is another thing that can be challenging because we have days where we're getting such a high influx of patients from our EMS services that we can't transfer people out. It's like they have no ambulances to take this patient to the next facility,
or you call
because they're bringing all of them in.
Right. And you call and that facility says we have no vacancy.
No beds.
Right.
Yeah, they're
No
waitlisted.
beds there. Or there's somebody that needs to, they need a flight crew. They're in such bad shape that a regular ambulance crew won't cut it. And
Bad weather.
The weather's bad.
Yeah.
It's raining or it's a dust storm or the winds are so high that they can't get on the helicopter. And
Right.
so you're like, okay, they need a neurosurgeon, which we don't have here, and we can't get them to one. So we're just going to do our best at this point. Those can make shifts tough.
given the nature of emergency medicine, you know that there will be times where a patient will come in and despite all the best efforts, that patient will not survive.
Mm-hmm.
How do you move from that to the next patient, or how do you move from that to the next shift? I mean, do you find that you take some of that home with you?
Yeah, I mean, for sure. There's definitely still cases I remember. Learning to have that short memory is definitely like a very challenging thing. And there's really difficult cases where you even like need a minute, like go to another room and just like have a minute to like decompress that thing, whatever caused it. But yeah, I mean, each case is very different. Like I said, there's ones I still remember from intern year that I won't forget. But yeah, it's a very challenging thing.
Most of the people that you will do everything for and don't end up making it are generally people that are very old and very sick. And, a lot of the times you can say, well, it was their time. There was a lot of chronic diseases that weren't going to get any better. Their quality of life was really bad. I did everything that I could. But the ones that stick with you are the young people that are maybe not so sick, that were hit by a car, or, Arizona has a problem with like little kids drowning in pools that don't have like proper fencing or that kind of stuff. So we see that every once in a while, and that can be pretty tough. So it can be, like Mitch said, sometimes you just need to take a moment to decompress. One of the things that helps out a lot is we do these like after a big incident like that, where everybody's in the room, all the nursing staff and respiratory therapy and all the techs and all the doctors are in one room trying to save this person, and then it doesn't go so well. You kind of get everybody together in another room after that and kind of talk about what happened. Yeah. And that gives people an opportunity to kind of vent their feelings, but also, debrief and talk about what went right, what went wrong, if anything could have been done differently. Usually we're asking those questions in the room. So most of the time it's more of just a way of like reassuring yourself that, well, we did everything that we could. There wasn't anything that we missed. And it kind of helps you be a little more at peace for that reason.
Yeah. I know that's kind of personal stuff, and thanks for sharing that, guys. Yeah. Tell me, as you reflect, now we said that the residency program is 3 years. You both have 4 months left, so you can see the light at the end of the tunnel.
Absolutely.
Tell me something that you learned here that you didn't expect when you were coming in.
I mean, outside of the crazy pathology that Kingman has, and there was, stuff you learned in med school that you put in the back of your mind and you say, I'll never see this in my career. And I've seen it here in Kingman, not ever expecting to see it in my career, multiple times sometimes. That's a big thing for me, at least as far as Kingman goes. Definitely, a lot of very rare pathology and a very sick population that really helps with your training.
Yeah, you get to see everything.
Yeah.
Dr. Doherty?
Definitely thought coming here that it was going to be small town feel, small town emergency room feel. And that is absolutely not the case. For one, Kingman has a pretty wide catch net. So we're like, you can go an hour in any direction, and those people are generally going to be coming here. I think because of the residency program, doctors here are forced to be a little bit nicer than they can be at places where it's just the doctor being the doctor. And so we will actually have people come over from Bullhead City and Havasu. They will drive the hour to get here to come to our emergency room specifically, just because they like the friendliness of the place.
Yeah.
But the volume here, and again, how sick those people are is huge. Kingman is about 35,000 people in population, and we see like 70,000 people a year through the emergency room alone. To kind of juxtapose that, I am moving to a city that is 100,000 people, and they've got a couple emergency rooms, but one of the ones that I applied at sees 30,000 people a year.
Wow.
So, almost 3 times the size of Kingman, and their emergency rooms are seeing less than half the people.
Wow. That says a lot.
And they have more doctors on those shifts than we have here too. So,
right. So this is like you're off to your retirement gig.
Yeah. That's every place that I applied. I was like, well, this sounds like an end of career job, not not first starting out when I've got all the energy, but honestly, I don't know that there's any place like Kingman that you could go get that experience at, that's why, so many of us wanted to stay here and practice here, but everybody wants to stay here and practice here. So it's really hard to get a job in the emergency room.
That's great to hear. Yeah. So my understanding is at a certain stage in your training, you're allowed legally to go and practice in other emergency departments. Have you guys done that? Well, first off, is that right? And have you done that?
Yeah, that is correct. And it's recently changed. I think this year, as third-year residents, you're allowed to moonlight once you apply for licensing and all that sort of thing. I believe they're changing that next year to, I want to say, in your second year of residency or in the midway through your second year of residency, you can moonlight.
That speaks to the need out there, right?
Yeah, definitely speaks to the need.
So have you done that?
I have not personally. It's a pretty lengthy process to get licensed, and there's kind of a short window when you begin your third year to get those things in to even kind of make it worth your while, because it is a cost,
Yeah, for sure.
Cost to get your license, cost to get approved by all these things, and then when you get to a point where you only have 3 months left after you get those licensing done, you're not making a whole lot of money from those 3 months of work to pay back,
And you're busy
everything.
enough here as it is.
Exactly.
Have you done any moonlighting?
I have not. We had talked about St. George's. In most states, you have to graduate from a residency program as a foreign medical graduate before they will give you a state license.
Okay.
So I can't get my own license to go do moonlighting until I've graduated, which is if you are from a U.S. Med school, then that's not an issue. They'll give you a state license. So I was unable to. I had set up for it. I'd planned for it, and I found out partway through the process that it wasn't an option. And people have different reasons for wanting to do it. A lot of the people that I've talked to are like, well, it's a good experience, as a doctor to go out. You don't have the oversight from your attending. You can go figure out how you're going to practice once you get out there into the real world. And having that kind of experience helps you hit the ground running when you get your first adult job. But also when you moonlight at these places, they pay you very well. Here in Kingman, our residency program, we have our yearly salary, and that is pretty good as far as residencies go because they're paying through the university, which is Phoenix cost of living adjustments, and that goes a long way in Kingman, Arizona. But Mitch is not married, no kids. I am married, no kids. And she works, so our expenses are not that great. We have a lot of residents in the program that have multiple children who the wife is staying at home with. So if they can get a couple of shifts in, making very good hourly rates, then I think that is more of a call for them than necessarily just doing it to get the experience.
Well, we said that you are both in your last 4 months here of residency. So I want to kind of challenge you here. Imagine that a brand new resident is showing up for his or her first shift. What kind of advice would you offer to that doc?
One of the things I would tell them is, take all the opportunities you can. Try and get involved early. I know every residency program has, their own idea of which patients are appropriate for a new first year. Some places have these graduated responsibilities where they don't want you seeing like a cardiac arrest as a first year coming in. But I would encourage, as your first year intern coming in to jump into all the procedures you can. Someone has a procedure that they're open to other people doing, jump in and do it. If they have a really sick patient coming in, if you have a senior resident with you, backing you up, encourage yourself to try and assess that patient and make clinical decisions and get used to that early. It'll make the process towards your second and third year much easier, and you'll feel much more comfortable.
Yeah. There are always going to be overperformers that will, if you let them see every person in the emergency department and you just get to sit back and not do anything. And like Mitch said, I would try to resist the urge to kind of coast because you have 3 years, which sounds like a long time, to kind of get it down to the point where you need to see so many things, do so many procedures while you have this attending there to help be your backup and help, correct anything you're going to do, correct mistakes before you do them. And once that 3 years is over and you're out there in the real world, you don't have that safety net anymore. And if you spent 3 years, doing as little as possible, then that's going to start to show up in your work. So yeah, definitely take as many opportunities. To a new intern coming on, I would say take a deep breath, because it can definitely hit the point where you feel like you've got too many plates spinning and something's going to come crashing down and your mind's all over the place and you're running back and forth, and just stopping and like taking a few deep breaths and kind of like clearing your mind for a hot second can help organize all those things into what needs to happen first, as opposed to you thinking I have 1,000 things to do and I don't know which direction to go to start.
That's good. Well, Dr. Doherty, you alluded to what's next for you in your career. You said you've already signed with an ED, right? Mm-hmm. That's probably enough. Is there anything else that I want to ask what's ahead, what's on the road ahead for you guys?
Yeah, I mean, to start, it's just going to be working normal shifts and, getting that experience in. I think that, both Mitch and I are the chief residents here, so there's some administrative responsibilities in that. I don't know Mitch's thoughts going forward about like trying to take on any administrative roles when you get to the hospital that you're working at, but that's always a possibility. Yeah. I've been making the schedule for the past year for the residents, and I have to say I'm very excited that is going to be done. So I'm not looking to go into anything regarding that.
Now they know that you can do it.
I know. I said it in the interview, and that was a mistake.
Right? You might have just volunteered for the job. Dr. Loehmann, what's ahead for you?
So I also just recently took a position. It's not at any one facility. It's actually kind of similar to like a travel position. Big group that, has a lot of these facilities where they're not fully staffed. So I travel to various states to fill in for these spots, usually like 3 to 6 months at a time. Okay. As Max kind of alluded to, I have no ties right now, no family, no kids. So I figure I might as well bounce around while I can. Don't really know where I want to end up. Originally from Chicago, don't really want to go back there. Mm-hmm. Would prefer to stay out west, but this gives me the ability to explore, many different states.
Awesome.
I'm getting licensed in like Tennessee and Texas and Indiana, so I'll be all over the place.
Just beware that they're all going to try to recruit you, so you have to be headstrong and, you have to be committed to living out of a suitcase.
Yeah, I'm okay with that for now.
Yeah. Oh, man. I'll tell you what, I was not a locums or a traveling doc, but I did my share of that.
Yeah.
I mean, it's an education.
Yeah, for sure. And you get to see how all these other hospitals operate, because we've been kind of enclosed in this one facility for 3 years now, trying to get to explore, bigger, smaller hospitals, higher, lower flow volumes, and being able to adapt to those things, I think will be really interesting.
Absolutely. And you may not have any ambitions later to go into administration, but just assuming that maybe someday down the road, the fact that you will have been in and out of all those different facilities, you will have seen what worked and what was totally dysfunctional in different places, right? And when you find yourself in a crappy situation, you're like, okay, well, I'm only going to be here for a couple of more months.
Yeah, exactly.
But you will have had a great survey of how things work and how things don't.
Yeah.
Right?
I think it'll be a great learning opportunity.
Yeah.
And I don't have any aspirations to do admin at this point, but maybe if I ever find out where I want to settle down and get to a facility for a longer period of time, maybe that will be a thing.
Well, if you need somebody to help you make schedules.
I'm actually. I'll give him a call.
Well, go ahead.
It'll be nice that you get to go to Indiana too, because maybe you'll be able to see your football team play.
Yeah.
He's a Bears fan.
I hope they never move to Indiana.
Moving over there.
No.
He's a Bears fan. I'm a Packers fan. So there's some,
this is good.
Animosity.
I'm from Western New York. And so, but I have to tell you, right? So I grew up a Bills fan. Still am, because you don't get to choose these things. But I love the Rust Belt teams in general. If it's like November, December, and any of those teams have a home game and the snow is falling and the great big guy with no shirt and the paint on his face, I'm watching that game.
Absolutely.
That's where I'm from.
Those are the fun ones.
I will just never understand why there's so many Packers fans in Arizona. Like, it makes no sense to me.
Because the alternative is to live in Wisconsin.
Yeah, I guess that's true.
All right, I'm trolling. In the moment that we have left, I want to ask you guys, I'm just the radio guy, but I'll give you permission to speak freely. Kind of reflect on how this program at KRMC has prepared you for these next steps in your careers.
So personally, one of the big reasons I went to this program was because of what I thought I would do for my future career. Because as we've been alluding to a lot of this, discussion already, is we have resources here, but obviously there's a lot of lacking resources. We don't have neurosurgery, we don't have trauma, we don't have all these, services a lot of big tertiary care centers have. And from that standpoint, it has really taught me to be able to handle a lot of these situations, a lot of these critical pathology on my own, and at least get them stabilized and onto the facility where they need to go. And that has, especially where I'm going into a travel job, where I don't know what these places are going to have that I'm going to, I feel like I can work at any facility I truly want to, because I've already dealt with, the minimal resources that I have.
Right.
And that's what I wanted from a program, and that's why I'm glad I went here.
Yeah, Dr. Doherty.
I agree 100%. The program here in Kingman, they really, really set you up to be able to work at an emergency room out in the middle of nowhere that has no resources, and be able to stabilize people and get them to those big hospitals that they need to be at. That being said, if you want to go work at one of those big hospitals in the big city, coming from here, you absolutely have the skill set to do that as well, because now you just have everything that you never had before, and it feels easy, cushy, breezy. So that has been, I think, the big thing about this program that has helped me out. It's nice to know that you are prepared to work wherever you have to, and be able to do a good job, and to not feel panicked.
Yeah.
Just because you're at a small place with not as many resources.
That's Dr. Max Doherty and Dr. Mitch Loehmann. They are the chief residents here. They're just about done. And guys, thank you so much for your time today, and I wish you the very best in your careers.
Absolutely. Thank you for having us.
Thanks for having us.
And that is another edition of Focus on Your Health. I'm TG Lafredo. Thank you for listening. We'll catch you next time.